Chapter 21, Incident Management. You should be able to identify signs of a hazardous materials incident when you're going out on the road. You got to understand how I'm going to take care of multiple different incidents, but I got to be safe as I go out there. Um, when we're talking about incident management, we're not only talking about hazardous materials. We have incident management system, and you have your IS 1, 2, 7, and 8 that you have to have for being on a department. But uh, let's also remember that it is a command system set up nationally so that we can integrate and operate with other people from other areas in a fairly seamless fashion. Now, when we talk about hazardous materials, we're talking about toxic, poisonous, radioactive, flammable, explosive, blah 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 blah, methyl ethyl kill you dead stuff, right? Um, and you'll be surprised at how much is rolling up and down the highway, how much is rolling up and down the railway, and so don't just go, oh, it's just a vehicle accident. You've got to be paying attention to the placards and the sides of the vehicles, and they could even be transport vehicles like a UPS truck or a FedEx truck. Uh, During a hazmat incident, top priority is yourself. Then bystanders. If we go down, no one's there to warn the bystanders, right? And so there's always going to be that one that doesn't listen, right? But you're going to do your absolute best to keep them from hurting themselves. We want to identify the substance as quickly as possible. Federal law makes people put placards on the vehicles, and they're supposed to carry a manifest of what's on or in the vehicle, in the driver's side compartment on the driver's door. So you can open that door and you can find that whatever they're carrying. And there's a four-digit identifier typically on the placard. Here's some examples of the placards you will see out there on the sides of the vehicle. And I challenge you to look these up as they're driving by. Actually, if you're driving, you don't do this. Have somebody else do it. But you're going to use this emergency response guidebook. This is your main thing, if you will, to identify what the chemical is or the material is, and what the first aid is for it, your safety zones, and how to clean it up. However, unless you've received training, just stay away, right? We want to be upwind, uphill, upstream. Otherwise, it's going to be up yours. And we really don't want that to happen, right? We want at least 100 feet. More is probably better, safer. And we want to make sure that dispatch knows we have a hazardous material scene going on and start taking precautions. Which way is the wind direction going? Is there another, if we're on westbound, is there an eastbound lane that's going to be contaminated as well? We want to try to get the people out of the contaminated area, but we only move them uh, if we don't ourselves become contaminated. That's why we have hazmat teams and firefighters to go in and do those procedures, decon them, rough decon to get them back to where you are. Full PPEs, right? That's what we're going to be doing. We care for them in the cold zone. We don't do warm zone operations unless we've been trained, and then we get them set up for immediate transport. There's very few specific antidotes. Most of the time, it's supportive care. However, if you want to know more, uh, there is additional classes that you can take. Okay, but for us in the emergency response systems, we're typically on treating the patients, not the scene itself. Now, when we talk about mass casualty incidents, now we've got some other things going on. They might involve a hazardous material component, but typically we're in vehicle crashes like I-94 pileups, 100 cars, bus crashes, train wrecks, major fires, blah, 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 blah. We can have multiple injuries. Now, a mass casualty anytime that I'm doing triage is the French word to sort. That means I have more patients than I have resources to care for them. Okay? I have more patients than I have resources to care for them. And we have to start thinking, uh, how am I going to get additional incoming units here? How am I going to get them out? Where are they going to go to? What hospitals? Do I need response unit, air response units? Do I need the National Guard? That type of thing. Um, and we might have to have a different kind of response. Maybe I'm going to use a school bus as a warming station or as a priority 3 transport unit. Obviously, some things other to think about it. How bad is it? If it's just a 100-car pileup with really no injuries, well, then it's just, you know, owie boo boo stuff. However, if in the middle of this accident you have somebody that's trapped in there and is bleeding badly, how can I get into it? You know, what's my access? Do I come in from a side road and just go busting through the fences? How am I going to get there? What's my response times? And what are the levels of EMS training, of fire training, of police response that we're going to get to this scene? Do we need to call in additional resources, right? And then, of course, the overall experience level of the EMS system that we have. Is it a brand new system that's never dealt with this, or is this a seasoned system that's dealt with multiple things? Again, our goal is to treat the most patients, do the most good, right? I will not divert resources to work on a CPR patient when there's 10 other patients that I could help. Person in CPR, if they need CPR, no pulse, no respiration, I'm sorry, they're dead. Move on. And you're gonna have to make that. You may have to make that call. Remember, priority 1 is red tag, is immediate. If I don't take care of them right now, they will die. They got to go to the hospital right now. Okay. Priority 2, yellow tag, delayed. Those are people that that can wait, but they have to eventually wind up at the hospital. These are the broken bones that you can't take care of by themselves, or huge lacerations or something. They're stable for the moment, and they can wait for the second round of transports. You have the priority 3, the greens, the non-injured, really, the non-urgent. These are the owie boo boo stuff that, in reality, they can take care of themselves, but for precautionary sake, they want to go get looked at. Okay, fine. Those ones will definitely wait to the last. But also, you have a priority 4. Now, priority 4 is actually segregated into 2 different colors: gray tag and black tag. Priority 4 gray, the patient's alive right now. However, based on the injury pattern that you see, you expect them to die. Your knowledge of the human body and the way that everything goes, you expect them to expire. Okay? And then the black tag, they're already dead. So priority 4 gray, priority 4 black, and we'll go from there. Now, that doesn't mean after I've got all the patients off scene, I'm not going to go back and check, because maybe, just maybe, they're still alive and for some unknown reason, they're going to survive. But based on your information, and you can't second guess yourself, you tag them and you move on. This looks pretty bad, right? We've got looks like a semi that kind of crossed over onto the other oncoming lanes. It looks to be at least 3 other vehicles involved, and he smashed one underneath them. And you got 2 of them behind. This could be a pretty bad one here, because we have not only the vehicles. Take a look at that semi. There is a placard there, but it's probably an empty container, because there's nothing in that placard. However, it could have been jarred free. So we've got to enter this very carefully. Right? We come in, we start with our visual survey. We're rolling up. This is what we see. I start guesstimating, right? I've got to start rolling resources. This is not a time that I can be precise. I've got to give dispatch a rough estimate update so that they can start dispatching other units, right? So if we go back to this scene right here, you're rolling up dispatch from Rescue 1. on scene with a multiple vehicle accident, one semi trailer overturned, 4 vehicles involved. Will advise on injuries. Right. That's that's what your initial. I just got goosebumps thinking about that. If that came over the radio, you have 4 vehicles, so you have at least 4 patients, right? At least, because there's 4 drivers. Now, if you have families and vehicles, now you've just upped the ante quite a bit. So then you get in there and you start looking around. You got to stay calm, right? Because we need to just do a quick look around. So as I give that update, as I'm rolling on, I've got my portable radio. I'm walking around. I'm careful not to step in anything. I'm careful not to cut myself. I'm looking high and low for people. I'm making sure that other people that are driving around this aren't looky-looing and smashing me in the stuff, and looking out for secondary crashes, because people are stupid. They will crash because they're not paying attention, right? That'll be a secondary thing. You got to take care of your primaries first. So you walk around. What do I see? What do I have? And then you can update information. Dispatch from command. We have 8 patients on the scene, 2 critical, 1 pinned in. Right. I'll need heavy rescue. I'll need 3. I'll need 4 tows out here, and make sure I have police to shut down the road. Right. Those are the things. They probably already have some of that already coming, but now it's for sure that you need these things. Clear language. Be calm. If you shout into the microphone, it'll distort your voice. We don't want to have that, right? We need to be able to communicate effectively. And if you've been running around and you're not in shape, you're going to be, dispatch, they're not going to be able to understand you. So please, please, please make sure that we're communicating effectively. Where are we at? What type of incident do we have going on here? Are there any hazards? How many patients? What else do you need out here besides what you already know is coming? Now, if we have multiple patients out there, uh, 5 patients, 1 ambulance, that's a lot. I mean, but that's assuming that you have like 4 greens and 1 that needs to be on the cot. Remember that people that are being loaded in the ambulance to be transported need to be restrained in there on a normal day, right? On a normal response, everybody's got to be doing the right thing. Now, when we're talking about mass casualty, kind of those rules kind of go out the window a little bit, but we're still going to have to make sure that we're able to care for people. We're not just piling them in and driving to the hospital, right? Now, I will say that the first on ambulance typically becomes the field hospital, right? It becomes your collection point, and most likely the ambulance people will then take medical command and start sorting and putting you to work taking care of patients. Um, but when we call out for additional resources, I need to know who's coming and who's going to be in charge, right? Maybe it's me. We need to make sure that we have ingress and egress of our units. Do we have a way in for our ambulances? Do we have a way in for our fire apparatus? And then as units start coming in, do we have somebody to direct them to where I want them to be? Because everybody's got their own idea of where it should be. There can't be, this isn't committee vote. Somebody's got to be in charge, right? And if we don't need vehicles and personnel right there on scene, make sure that there's a staging area away from the scene, right? We live in rural EMS, rural country, right? And sometimes we have people responding in from home in their personal vehicles, and we have 35 personal vehicles in this stinking way. How are we placing those, right? Where are they going to go? Now, I've already told you triage means to sort, right? Triage means to sort. It's the French word for to sort, and it's going to be simple and fast. 60 seconds or less. I prefer 30 seconds or less. But basically, you're going around and you're doing an ABC and mental status evaluation. Buddy, are you okay? No, I'm hurt. Really? Where are you hurting? I'm bleeding out here. Throw a tourniquet on, move on. Right? That's the way we go. I know that he's breathing because he's talking to me. I know he's got an open airway because he's talking to me. And zombies don't talk and breathe, so he's got a pulse. Stop the bleeding, moving on. We don't have time to sit there and fix everything. It's a, here's, I'm tagging you. Somebody will be around to help you. We're not forgetting you. I've got to move on and help other people at the moment to sort them. There's multiple different ways of doing it. I like the tape method here to the left there. Quite frankly, though, there needs to be another thing. Actually, the green should probably come out of the bag, and there should be a gray tape that goes in there. Because if you're green, why do I even waste time to put green on there? I don't even need time on it, right? But for the nicety's sake, maybe you put green on there. You just rip it off, tie it around the wrist, tie it around their ankle, moving on, right? There are tags too that you can put on them denoting these same things, and you can write a little bit of something on them so they have the beginnings of a report there. Again, we've talked about this, but here it is for you to write down, right? Priority 1, got to go right now. If they don't go right now, they're going to die, right? So we need to get them out first. Priority 1, red tag, immediate. Priority 2, yellow tag, urgent, means I can delay them for up to an hour. I don't really want to, but because there's reds that need to go out first, we take care of them. The 3s, these are really, again, the probably could take care of themselves, could probably find transport to where they need to be, but they can wait for, up to 3 hours. Now for the 4s, the gray tags, the black tags, those ones don't need any special care. If they've expired and they're in the way, we can move them to a morgue area. We want to make sure that when we're placing them, we're not placing them anywhere near the living, because that is just mentally damaging to those that are alive. First step in START system. You get on your PA, you say, if you can hear me and you can walk, please move over to, and then designate a specific area. Now that doesn't mean that the people that are walking aren't severely injured, aren't critical, aren't priority 1s or 2s. But what it does mean is I've got people that are conscious and able to respond, so they're not as bad as the people that don't move, right? Patients that can walk rarely have life-threatening injuries, that's true, but most of the time, or some of the time I should say, you're going to have patients there that are following the crowd just because they're moving and they actually have a severe head injury. So we got to be careful about just assuming that anybody that's walking is walking wounded, priority 3s, right? Then where I start is I move through anybody that didn't move. Anybody that didn't hear me or anybody that didn't move to the designated area, I start looking through them. We come through and we do and assess everybody. Now, as I'm assessing them, I'm tagging them, and behind me comes the treatment teams. So triage teams are out there sorting, right? And the treatment teams come through. They're looking for the reds. They find the red. And then they stop and they evac the reds to the transport area. Right? That's what we're going to start doing. We correct the ABC problems and move on. We actually have to do the ABCs and mental status. Are they with us? Are they conscious, unconscious? If they're unconscious, they're automatically a red tag, right? We have to make sure that they're breathing on their own or whatever, but they're a red tag. Moving on. Oh, a fun little thing here. Red, yellow, green, black. If their breathing is out of whack, they're priority 1. We can't stop and breathe for them, though. We can open their airway, but we can't stop and breathe for them. So if they're not breathing after we open their airway, black tag them and move on. Yes, they might have a pulse, but I don't have time to divert resources. Now, if I have a treatment team right there, they can start their work and I can move on. But I, as the triage guy, cannot stop until everybody has been seen. Now, if we have multiple triage teams working, multiple triage persons going out there, then of course, once we clear all of the triage, we can swing back and start helping. Circulation, we check at the carotid. If it's not at the carotid, it's nowhere, right? If it's not at the carotid, it's nowhere. Have them lay down. You can begin to treat for shock, but I don't have time to do a full treatment plan. If there is no pulse, they're gone. Priority 4. They respond to verbal stimuli, or if they respond to you at all, they're a 3. If they're unconscious but responsive to painful or verbal stimuli, they're a priority 2. But if they're completely out, they're a priority 1. Right? So obviously, the worse off they are, the more you're going to have, the more they go up the severity list. START is designed to find the most serious injured patients first, and then come back through. Not all patients stay in the same condition. They might start out as a 3, and then all of a sudden internal injuries or whatever, and they begin to decompensate. So we have to check and recheck the 2s and 3s, especially that group that moved. Hey, they got up and they moved. There should be another somebody sorting there and beginning to put people in a transport area. So basically, you start where you're out, call out. Walking wounded and non-walking. I'm going to be walking wounded is typically minor. We want them to go to a specific place, and then I'm going to triage them based on what I see on them. The other group, the non-walking, are they breathing? Yes, no. If they are breathing, if it's under 30, how are they doing perfusion-wise? Radio pulse present, we're good to go. Now I check mental status. If it's absent, they're gone. Right? No radio pulse, or excuse me, yeah. Well, no. Why did they put radio pulse on there? So if they don't have a pulse at all, we're done with them. But if the radio pulse is absent, but they have a carotid pulse, now they're a priority 1 because they're bleeding out somewhere. Right? Follows commands, can't follow commands of the mental status, delayed versus immediate. If they're not breathing, they're gone. So no pulse, no respiration. Call that what it is, a death. Now, if you are not the first person to arrive, rather than jumping into the middle of it and redoing other people's work, you find the incident commander, because they will know what's going on. They'll have a bigger picture, and they will tell you what to do. And once you complete that task, you report back to the incident commander so that he can give you another job. Your job is not to run the scene if you are not the first one there. But if you are the first one there, you need to establish command and begin the process. You might hand it off, but you need to start. Initial overview, clear communications, and begin triage. As more highly trained personnel arrive, report your findings in person. Okay, approximate number of patients, how many people you've tagged, additional resources requested, and other important information. They may have you stay in operational command of the sort maneuvers, and they might just start treating. In either case, you still need to get off a handoff report. Now, the NIMS system has been developed by the Department of Homeland Security. Further developed. There's always been parts of it out there. And it's used to handle big responses and long-term responses, including recovery from natural disasters or terrorist attacks. Right? Now, 5 major areas addressed within the scope of NIMS is we have the command, right? I only see 4 here. Why do they say 5? Fundamentals and concepts of NIMS, resource management, command and coordination, communications, information. There's actually more than this right here. But we also need to understand patient care is our priority. So this might be left for the white hats up top. Again, I talked about NIMS courses 100 and 200 and 7 and 8. I know they've changed some things out since we've been in the field for a little while. 1 in 7, I think, are the introduction classes to command. And not everybody is going to be a command, but everybody needs to understand command. Terrorism awareness. We have to be eyes up. If we are dispatched to a bombing or a chemical release or whatever, be very aware of secondary devices, because a terrorist wants people to be hurt. They rush to a specific area that is logical, and there's already a secondary device there or a secondary attack designed to wipe out the rescuers, which maximizes civilian suffering and pain and death. Right? It could be within the country, local or domestic or a foreign terrorist. We got to be aware of where we're at and what's going on there. All kinds of different things. Terrorists don't care. Terrorists are bad people, period. If they are terrorizing the populace, well, then they're not doing it. I mean, they're just creating havoc. They're going to use guns, explosives, fire, probably combinations of all this stuff. The more long-term and insidious chemicals, viruses, bacteria, radiation, and then with these last several, it can contaminate others that are not even close to the incident. And so we have to be very aware of our hazardous materials procedures and the safety protocols that we have in place to decon these people. A terrorist might use a weapon of mass destruction. It's designed to bring about mass death in an instant, right? Now, that could be a bomb, but mass destruction, typically, we're thinking about world killers like nuclear weapons or biological weapons. I mean, if the conspiracy theorists are true, a pandemic could be a weapon of mass destruction. Typically, right now, WMDs have been explosive devices, but you just have to be aware of our changing world. Obviously, when we're talking about WMDs, we're talking about highly populated areas. And we're going to use things that will disrupt infrastructure as a target. Bridges and tunnels and pipelines and harbors, places to get people into and out of, that's going to be targets. National monuments, because there's a lot of people there all the time. Housing developments. You also have schools. I mean, we just had several shootings. These are places where bad people do bad things, not necessarily because of what they have, but because they're just bad people. And then, of course, you've got the computer systems. If you shut down computer systems, does that shut down power? Does that shut down communications? What is that doing? Some examples of potential targets, right? No one actually thinks about these until they're destroyed, right? Think about this, that lower right-hand corner one. How about the emergency rooms? I'm going to wait till the hospital's full, and then I'm going to blow that one up. Always be alert for hazards. If it looks wrong, it is wrong. Don't just assume that it's trash. Don't just assume that. Don't be in denial. Be alert. Be hyper vigilant. Right? You see one of these? That's not normal. Okay? This is a simple bomb, and you have to make sure that you're paying attention, because you see this. This is very dangerous. Right? And maybe this is a dud, but I'm not going to take any chances. Safety first, right? If we know that there's an area that's got potential bombs or grenades or whatever, we're not going to enter that until cleared by a trained professional. And you are not the trained professional. Just because you work in EMS doesn't make you highly trained, right? Always be aware for that second explosive device. Criminals are pretty predictable as far as that goes. There's always a secondary or at least a secondary plan, right? Think about many of the shootings. They have weapons stored other places. They've already planned this out. So there's secondary areas of damage. Um, we have to be paying attention to all of this. We want to be upwind, uphill, upstream, because we don't know what they've got going on there, and I definitely don't want hazardous materials after the release of whatever they're going to do to come towards me. Most of the time, it's a pulmonary agent, something that affects the lungs. You breathe it in, and you start coughing and gasping like mustard gas or any of that kind of smoke bomb type things. Um, you could have some metabolic agents that come at you. The cyanides, typically if you're exposed to that, you're pretty much toast. But there is the 2-PAM, the duodotes, I should say, that you can use to counteract some of these chemical agents. It's not widely available. It used to be on every emergency unit when it was a bigger threat, I guess. Uh, but they expire, and it takes a lot of money to keep those uh, fresh, if you will. We talked about this in our, and this is why you give the duodote. We talked about this in our poisoning overdose. The organophosphate insecticides or nerve agents. They're going to do sludge, right? Salivate, lacrimate, urinate, defecate, gastrointestinal emesis, right? And then they're going to have some problems with their motor skills, right? So when we see this sludge-like symptoms, you know that you've been exposed to a nerve agent. This is where you need to have your atropine and your, I can't remember the other part of it. Anyway, it's part of the duodote. One of you dries you out because you're leaking from every orifice, and one of them increases your heart rate. Saren Soman, I'm not a domestic terrorist expert, but these are some of the things that'll happen if you've been exposed. You might have burn-like blisters, severe shortness of breath. Um, make sure that we're getting them oxygen. Make sure that we are uh, protecting ourselves. This might be an instance if you have a half-mask respirator that would be better than that filters out gases. That would be better than just the N95s. Anytime multiple people are dealing with similar symptoms and you don't see any trauma, you've got to think that it's a chemical something, whether it's on purpose or an accident, right? We need to avoid contaminating ourselves and other rescuers and bystanders. We're going to start looky-looing, right? And you're going to have to help those that need help to not contaminate everybody else. And that's going to take a fair amount of discussion because they're hurting. They want to be cared for, right? A list of different types of things you might see. Um, I'm not going to cover each one of them. Be aware of that. And again, unless you are part of this chemical response team, probably not going to know most of this stuff. Basically, if you're smelling bleach, almonds, or garlic, you're pretty much having some issues with your day here. Again, with the biologicals, that could be a naturally occurring substance that produces disease, but it is they're released to cause long-term sickness. So you're fine for a couple of days and then blam. Watch the ERs if they start ramping up. There might be a secondary thing that you have to deal with. You as EMRs may not be dealing with that, but in a mass casualty where it's a long-term response, you might. Safety considerations when dealing with biologicals, standard precautions. Make sure patients are fully deconned. That means their clothes are off, they've been rinsed off, they've got some scrubs or something that they can put on, or a blanket to wrap up in, and we make sure that they are not carrying it on with them. Radiological agents, typically speaking, if it's a low level, you might be just nausea and vomiting. The higher it gets, the worse it'll get. You might even see partial to full thickness burns, cancer, and death. The cancer part obviously won't happen right away, but they might start bleeding from orifices and looking horrible, right? And so when you have that kind of radiation, human beings don't deal with that very well. There are Geiger counters, dosimeters, if you will. How long can I be in a specific area before it becomes lethal to me? Um, we haven't dealt with these in my brain, we never do, but this is preparedness for that event. Now, in all emergencies, it is scene safety and control that is going to be the best. Notice we've got cars everywhere, parked sideways, kittywampus, and all that. Multiple people. I mean, look at that gaggle of people in the intersection. You got police trying to control things. This is insanity, right? Because you've got people coming to look, which I think most of those are, and then you've got whatever accident scenes going on there with all the engines and the ambulances and so forth. Be prepared. You have got to do your training. You've got to train with your teams and other people's teams, and you may not like them, but you're going to have to work with them, especially in the event of a mass casualty, right? Many types of terrorist events require us to stay a certain distance away to avoid contamination, but civilians don't know that, so you're going to have to tell them, hey, don't go down there. Well, my kid's down there. We're going to get your kid back, but you going in there is going to make it worse, not better, right? And again, be alert for secondary devices. Obviously, we're going to establish ICS. Incident command system can be used for just large events, but you have to know what your role in ICS is. Now, with a terrorist attack that's involving many, we're going to treat this as an MCI. We have to have ingress, egress. We have to know where we're going. We have to, take care of the civilian population, make sure our responders are getting in there, and make sure that we're always reevaluating for scene safety. And then again, we're going to activate other agencies, local, state, and federal agencies, to back us up. Maybe they take over, maybe we back them up. It doesn't matter. It doesn't matter who's in charge as long as the job gets done and the civilians are stabilized and safe. All right, that concludes chapter 21. We're going to give you a couple of slides of summary here, right? Now, during a hazmat scene, your top priority is to recognize that it is a hazmat scene and make sure to protect yourself and bystanders from becoming contaminated. During a mass casualty incident, we're going to use the START system to sort out patients, right? Red, yellow, green, gray, black. NIMS is that framework that we use to do a unified approach to a response that is bigger than any one agent. Remember that the goal of terrorists is to intimidate a population or government to achieve their goal. And they do it by explosives, fire, chemicals, virus, bacteria, radiation. We have to be ready to respond to those things. Some of the pulmonary agents used in chemical attacks are very, they're crippling. But we also have metabolic agents, nerve agents, pain agents, blister agents, if you will, and the organophosphates. The Oklahoma bombing was organophosphates. Biological agents are organisms that cause disease. Radiologic weapons are mass amount of destruction. Those are our WMDs. They're also known as dirty bombs. And when responding to anything, EMRs need to consider their safety, safety of the rescuers, safety of the bystanders, and everybody else whenever we're dealing with not only terrorist-related events, but all events. This concludes Chapter 21.